Hey y'all, happy Baby Friday. Thanks for joining us today. This is Betty with Compliant Healthcare Solutions, and I have my dear friend and colleague with me today, Pam Vanderbilt. Hey Pam.
Oh, hello, Betty. Hello, everyone else.
And we are both Florida. I was going to say they have the Florida man, so I don't know, maybe Florida woman, I don't know, but
That's us.
we're down in the great state of Florida. And I see we have Maria that has chimed in to us already. So, hey, Maria, how you doing? So for today, I thought it would be a good idea. Pam is the owner of Knowledge Tree Billing, by the way, for those that of y'all that aren't familiar with Pam, but I'm sure if you've been in chapter meetings or seen things, everybody probably knows who Pam is. But she owns Knowledge Tree Billing, so she has a billing company, billing service, and she and I actually have a mutual client. And when she was speaking with someone at the practice, she was explaining to them things because I had been was looking to do some auditing services for them. And we had been looking at some of their, practice stuff. And Pam and she had been talking about the revenue cycle itself. And the woman, and I'll let Pam tell the full story, but the woman didn't seem to kind of understand what all was involved in revenue cycle, or she seemed quite surprised as Pam went through the things with her. And it just made me think that it would be like a nice broadcast to have where we talk about not just one piece of something or one piece of something else, but kind of the revenue cycle as a whole. So that's where kind of my idea of this, when I pitched it to Pam, I was like, well, hey, why don't we do, the entirety of the cycle? And of course, Pam, being my good friend, was wholeheartedly jumping in on it. So that's what, we kind of wanted to talk today, like kind of soup to nuts kind of thing. And this, if y'all have questions or comments, we certainly, appreciate them, and we'll, try to answer anything we can. I see Teresa is with us. She is an oftentimes listener. So, hey, Teresa, hope you're doing well. So yes, Pam, if you would tell the story of, the conversation and the education, that you went through with the lady from our client.
So we'll call her Betty.
Okay.
No, we won't call her Betty because we have knowledgeable Bettys on with us. But it was kind of interesting when Betty reached out and what we were doing the project initially. It kind of became apparent after we were delivering our findings that the practice didn't understand the difference between a revenue cycle audit and a documentation audit. And so one of the things that we noticed going through it is they had some issues in their RCM in general, right? But a big part of that is the documentation. So when I was having the call with Sally, we kept talking about, you need to do this, and this is part of it. And these, the front office, you need to train your front office staff. They need to know how to recognize an insurance card. They need to know if it's red, white, and blue Medicare, but they don't have a Part B effective date. You're not billing Medicare. There's something else we need to know, right? And a lot of times we think from a revenue cycle perspective that once we get a super bill or once the provider signs their note in the EMR and we start putting charges in, that's where the revenue cycle starts. And that it could not be further from the truth. The revenue cycle starts actually at that initial phone call to schedule the patient's appointment. Are we getting the correct information? Are we having a conversation with them about what insurance do they have? Are we in network with that insurance or out of network with that insurance? Did we get the right phone number? So when we do our reminder calls for the appointment, that they actually get the reminder, what are we doing that work on that phone call right? And then when they come into the front office, those are the most underpaid people I've ever met in my life.
Oh, yeah.
Because the practices seem to think that that's just an entry-level position. We could pay them minimum wage. We don't need to do anything. They just need to put some stuff in the computer and
Yeah.
not be put further from the truth. Because
Yeah.
when we give that patient in whatever format we do, whether it's paperwork or we're doing it on a kiosk, that person needs to understand that if there is something we ask the patient and they don't answer it, there's a reason we ask the question. We do not ask for any information on that demographic paperwork that we do not need to know the answer for to get paid or to get paid by the payer appropriately. So some of the consents and the acknowledgments that we're asking for, right? Not understanding the difference in the insurances. Most of my clients are on eClinical Works. Their eligibility runs in the background at night automatically. Just because it gives the yes, the green light that that insurance is eligible does not mean that that front office doesn't need to open it up and look at it. Because guess what? Once a patient has a red, white, and blue Medicare card, it's always going to say yes.
Uh-huh.
That doesn't mean that we're billing Medicare for those services. We need to look at that information. Medicaid, different states, everybody's got different Medicaid, but same concept. They have the CMOs. I call them Medicaid advantages. Your Medicaid eligibility is going to say yes, it's good to go, but that doesn't mean we're billing Medicaid for that state. We may be billing Sunshine, or we may be billing Peach State, or whomever it is for that state. So not valuing that front office position enough is a huge mistake. And then, oh, by the way, patients owe us money at the time of service. You've got to have a personality that is going to look at them and say, Betty, today you owe me $300. Will that be cash, check, or charge? And not just go, do you want to pay?
Yeah.
The answer's going to be, well, no.
No.
Yeah, well, we're not getting paid for your visit. Because if we didn't collect it on the front end when the patient's feeling bad, after they feel better, they have no incentive to pay us, right? And then patients get back in the clinic, and I'm walking Sally through this whole process because she doesn't understand that it's not just a billing function, right?
Right.
Once they get back to the clinic, one of the things that we noticed was kind of a pattern. They see a lot of hospital patients. We saw a whole lot of 3s, some 2s. We didn't see any 1s. And so we've got an issue with code selection. Is that the provider making those selections? Was it the biller doing it? What are they actually documenting? Are they capturing the information about what's happening today so that we can report those services appropriately, right? And so one of the big things that we were trying to communicate back when we had the call with Dr. Sally and when I had the call with Dr. Sally's wife, Sally, is they need a documentation audit, because some of what we were seeing in the revenue cycle was the payers were asking for documentation to support the services, prepayment. That's a really good indication that maybe we've got some coding issues, and we need to know, is it coded correctly and supported by the documentation, or do we have another underlying issue? And they're like, well, we just did the audit. No, you did an RCM audit. We're telling you where the problems are. Now we need to take a deeper dive into each of those problems so that we can correct them and make your practice keep the lights on and be profitable.
Yeah.
So, it's a whole, I think we all kind of get the billing side of it. We're going to make sure the charges are clean, send the claim out, post the payments, do the denials and the appeals and all of that. But it's everything before that people just don't realize.
Yeah. Well, when I talk to people about it, I'm like, well, that's why we don't say billing. Billing is billing. We're talking about the revenue cycle. It's a cycle, meaning there's moving parts and pieces, and it's kind of multi-fingered, to go out and touch a lot of different things. So you kind of have to, when you think about it, broaden what you're thinking about out, because you can't get to the billing part of it unless these other parts of it are done and done correctly. And Rosemene, hey, Rosemene, she, put a good comment out there about the front office that, the front office can make or break your revenue cycle, which is true,
It's very
and I agree with you, Pam. When I moved into practices from, from the hospital where I was, I kind of did some time, I put my time in at that front desk. So, and it, you do think about that a lot of times at the practices, they are the least paid, the most worked, and, you're answering phones, you're checking people in, you're checking people out, you're adding the demographic information, I mean, there's so much that's going on. And if patients, when they're checking out, if they have something about their balance, then you're trying to look at that and you're trying to make their next appointment. I mean, those people are do highly too much work at one time, in my
Yes.
opinion.
And there's a lot of turnover because they're
Yes.
so underpaid that they can go work at Zaxby's and make more money.
Yep.
To do less work,
Yep.
And so if we're not valuing them and paying them appropriately, we're going to have turnover, which means that we're always going to have a suck of knowledge.
Yeah.
That we're going to have to train somebody else from the start, right? And
Yep.
Rosemene also does what I do, so I think she can feel my pain because we're not in the office where we can beat them over the head and say, this is what you need to get for us to get you
Yep.
paid. But being able to interact with our clients and kind of help guide them and teach them. And one of the first things I ask a new client is, what are you paying your front office? Because our success as a billing company is dependent on your front office success. And if you're treating them like that low entry level minimum wage person, you're going to have turnover and none of us are going to be successful.
Yeah. And that's too, I try, I with offices, how when you go to the office, and I know a lot of people when they go that aren't in the field, you go to the office and they always ask you, did your address change? Did your insurance change? Did your what? And they always are like, I hate those questions. You ask me every time. Well, there's a reason we ask you every time. I mean, you see how many patients are in here and how busy. I wouldn't be asking these questions of you if that's not information that we needed to know. So it's important because maybe, you forgot that, oh, that's right, this switched over this month, or, I now have a different supplement. And, or if you have Medicare patients, sometimes you're asking them because they can't remember, oh, well, last time when I came in here, did I have this? Did I have that? They can't remember. So,
exactly. Or they don't know.
No, that's very true.
Because they can't see what we have in our system, right? So if I only see my doctor once every 3 months, and right after I saw my doctor, I moved.
Yep.
I don't remember if I updated my address. So if the question is, has your address changed?
Yeah.
They may know. They may not, So we have to ask intentional questions. Are you still at 1416? Yes, I am. Okay, good. Yep. I see that you've got Humana Medicare Advantage. Did you get a new insurance card? Be intentional, not has anything changed, because they're not looking at our computer. We are.
That's right. Yes. And I think the sometimes with the front office staff, they've gotten so much negative feedback about asking the questions all the time that they've gotten it down to where it's just like, I'll just say, has anything changed? Because it's easier for them. And it's easier, it's like I'm trying to make it just a less thing to get people all going when they come in the office. So it goes back to that. What are you investing in your front office staff and how they go about doing their job?
Right.
Because it just makes everything down the line flow a lot better. And I remember at one place I was working at, the front office would always complain about what the back office and vice versa. Well, they're not doing this and they don't understand that. And how come they can't do this? And, so I had them switch places, So I
walk a mile in my shoes for a day.
And I was like, now do you understand why they get upset with you when you say that you checked with the patient, but we're getting this and it's stating that the stuff isn't valid anymore, and now we have to refile, we have to call the patient, we have to get the right information. And then same thing with the back. I said, now do you see why sometimes it's hard for them to be getting
Exactly.
that information when they're also got all the phones ringing and the doctors coming up and so I think everybody to have a good understanding of that too, is very helpful, because then you kind of appreciate, what the other areas go through. But yeah, it all has to go together and work as smoothly as possible, to
Exactly.
make everybody's life go easy, and we get stuff paid, and you get it paid right the first time. Because that's the thing. I mean, we can get paid, but it's about getting paid right, getting paid now, because your $100 bill today, if it takes you 7 months to get paid, is not worth $100 anymore. If you get it paid the first time you submit it, you don't have to touch it again. Well, that's much better. So those are the things when you look at like what's eating at your practice's bottom line, stuff like that is what eats at the bottom line. Looking at how much it costs to have to refile and have to appeal and have to, I'll do all that silly kind of stuff. That's all people's time too. It's not just pushing a button. They have to do something. They have to work it, and every time they touch it, that's money. That costs money. So those are things all that play into the stuff with the revenue cycle, because it's the cycle, so we need to make sure that we're closing that circle. And in Teresa was when we were talking about the front desk stuff. She said when she worked working, I work with so many people that were not firm with patients. You have to have a certain mindset and personality to do this role. So that definitely is what we're looking at with that front office staff. You have to be able to ask those questions and to do it in a manner that, of course, you're not going to be upsetting people or not upsetting them as much as you can. Some people, no matter what, they're going to be mad if you're asking them for money, right? But,
exactly. But the reality is, you don't go to Walmart and expect to walk out with merchandise without paying. We're talking about something far more important than merchandise. We're talking about your health.
Right.
And there is a cost to getting good health care, right? And the ones that kind of, I think that the best way to find front office staff, because I think of them as the hostess with the mostest. They have to be like the best friend. They have to have great customer service. They have to be able to deal with the negative, right? And some of the best people that I've ever seen working in a front office were people that the doctor met going through the drive-through at Chick-fil-A, or going to Moe's, or other businesses that put a focus on customer service, because you can't really teach that customer service personality, but you can recognize it when somebody has it, right? We can teach the insurance piece. We can teach why it's important that everything that we ask them for in that demographics is filled out, right? But we can't teach the personality to be customer service oriented and still have confidence asking for money.
Yeah. There's been many practices, and you and I've talked about this multiple times on the front desk issue, where I have gone into a practice and the person that's they don't even look up. The door, they hear you coming in, but they don't even look up from what they're doing, or they're sitting there on their phone as and then you walk up and you're standing there at the front desk staring at them. They haven't even acknowledged your presence yet. Things like that, they just get very aggravating. And that stuff like that kind of puts the patients on that, like, attitude-y kind of thing. So then on top of that, after you do that to me, now you're going to ask me for money. And so, I mean, you start out where it's not really that great, so yes, you need that person to, be welcoming people. That's the face of your practice. Is the first thing they see when they come in the door. You want that to have, what your philosophy is for the practice needs to be embodied in that person at the front desk. Plus, on top of that, they need to get the job done. So I mean, yeah, it's a very important position. And I think from years ago, like when I first, again, I'm a dinosaur now, but when I first started in 36 whatever years ago, I mean the whatever we sent out, we got paid. We would give the encounter forms to the patients for them to submit to their insurance. We only submitted if it was Medicare or Medicaid. There were no PPOs, there were no HMOs. So the front desk person, it was more of a, like visity kind of, hey, how y'all doing, when they come in, and and I think that mindset has kind of stuck with some practices, and and with how, so the value or how they look at it is on that, well, they're just kind of a greeter, and there's just so much more to that, and I always fight for those people and saying, they do a whole lot, and this is how you're getting your money, and how you're getting it started in is by these people right here at the front desk, and just on the money side, Rosemean had added how much they were making. Yeah, she said in Texas, the front desk people are making $10 an hour.
Fast food's paying more than that now.
Exactly.
We're not going to keep good people if they can go get a job somewhere else making more money.
Yep. And then Teresa answered that it was terrible that she was making $7 an hour back in 1996. So it really doesn't. Yeah, that's a shame. Those people need to definitely be paid more than that.
It is. And and I think, and I know this is not popular opinion, but whoever your lowest paid person in your billing office is, your front office staff should be making at least that. And we do kind of treat our billers a little bit more. We pay them a little bit more, right? But I think that goes back to the concept that your revenue cycle starts in the billing office. And that is the furthest from the truth it can possibly be.
Yeah. I think that's it. In a lot of practices' heads, that it's billing, so that's, they get that's where we get our money from, but to get to that, it starts at the front office. The front of the house has to be able to get what they need. But also Luann Friedman said, and Luann, you're showing up as my LinkedIn user today. There's always one over on my thing that shows up as LinkedIn user and not as their name. Usually it's Sonal, but Sonal's on the road. So I knew it wasn't her. So Luann said that you made a great point, Pam, that it is much easier to teach the insurance skills than the personality and customer service. She also notices that when retail and hotel staff are exceptional, and that's because that's their mindset. So I totally agree with that. So in looking at the revenue cycle, from besides the front office kind of stigma and issues that we were just opining about for a little bit, what other things do you think are challenges that you face managing the revenue cycle, and that practices have, especially lately?
Is insurance payers an exception and a reasonable answer? I think I could go down so many different roads answering this question. Some of it is just kind of frustration, because it feels like sometimes there's a denial of the day, that somebody at an insurance company says, if you get a claim today that has upper respiratory infection as the diagnosis code, deny it for no necessary reason. It's just the diagnosis of the day, right? And then we have to go back and touch it. I think that's very frustrating. And oh, by the way, I'm being a little bit funny, but the reality is they do that. I know people that have worked in with payers before, and they do it. So if they tell you they don't, they're full of poo-poo. You ask somebody that's worked there, right? But it's still, I've got to tell you, I think technology helps us a lot. It can also work against us. Posting payments, electronic remits. I just took over a client that nobody had set up for them to get ERAs. They were manually posting remits. And I'm like, why? Why would you do that? Well, time wise, I don't think it makes sense, but we can't fall into the trap that when we post it electronically, we don't need to still open it and look at it. Because if we don't look at what happened on that remit, they may have inappropriately reduced our fee. They may not have paid us on the right fee schedule. They may have denied something in a way that should not have been denied, and we need to appeal it. If your system is set up that when something is denied, it automatically takes the adjustments, you're not going to see it unless you open the remit, right? So just because we use the tools available to us doesn't mean there's not still work that we have to do. And I think that there are a lot out there in our industry that don't realize that. They're not cognizant of the fact that we have to take the time to look at it and understand what it says. For example, I had a remit that I was looking at. It had been posted electronically. I go back through them and look at what's going on. And there was a line on the remit that denied. So it had flagged. When I opened it up, this particular patient had had their preventive service. On the same day, they had an evaluation and management service.
Mm-hmm.
And the payer, that I won't mention who it is, but we all know who it is because they've been in the news a whole lot lately, reduced my E&M service by 50%. And I was like, hold on, wait a minute, because I expect that from some of the Blues and people who have policies, right? I had to go back and start searching, not Blues or Humana or Cigna or Aetna, policy on modifier 25, preventive and E&M. And sure enough, there's a document out there from February that shows that if you do a preventive and an E&M on the same day, they are going to reduce your E&M by 50%. I have an issue with it. That goes back to my whole modifier 25 issue, but I have an issue with it.
Yep. Yeah, I the same thing with the technology. I remember I had a client that when I was looking at their stuff, they called me in because they said, we can't understand why our AR is getting so, like it's just getting really, really bad. And I don't get it. And so when I was in there doing stuff and looking at their, was asking them about, how they were sending claims and how things were done. And they had switched over to this clearinghouse, and the office manager was newer. And she said, well, they told me, at night, I could just push that button and stuff goes off. And I said, okay. And I said, and what about, the reports that come back, that are telling you like things are missing or things are pending or things are, and she looked at me again. She said, I just push that button and they get sent off. And I was like, yeah, I understand that part of it, but I'm asking you, like the next day when you get the report that comes back, well, no, I just push the button and it just goes off. No clue. So we looked, and of course, there were months worth of things that were pending and denied from the payor out with errors and all. No clue. Because she was pushing the button and she thought when she pushed that button, just magic happened and that was it. And she was done touching it. So it can be interesting inviting that stuff in. It can be very helpful in one hand, but you still have to follow through with things when you're looking at it. There really isn't a magic button.
There isn't. And we actually just had this, we found it today. I have a practice that the provider does a good majority of his charges come out of hospital visits, and we get asked for records all the time. So his AR in aging days are not in line with most of my other practices. But it just kind of I was looking at the total AR and I'm like, this is not adding up in my head. And so, I filtered my claims that were still sitting there by payer. And all of a sudden, I had 9 pages, 20 encounters per page, 9 pages that started with Aetna, regardless of what plan it was. I was like, hold on, wait a minute. And so I went back and I filtered out our payments all the way back to February 21st, the magic date, right? The big change for each.
Yep.
And electronic payments wise, we had not gotten a payment from Aetna since February 28th in that practice.
Oh man.
Now, Trizetto, which is the clearinghouse that most of my clients use, had reestablished the connection for ERAs last month. 2 practices have we gotten a remit from since they did that. There is some issue, some box that's not checked in the background, right? But it's affected all but 2 of my practices.
Mm.
And I'm like, well, thank God I found it in this practice, because the other ones don't have the same volume with Aetna.
Right.
So who knows when we would have found that, you know? But that whole, you got to be looking. You got to
Yep.
pay attention. Why is something not quite right? You know, so we rely on all of that electronic stuff, but we still have to put eyeballs on it. And then we
Yeah.
have Teresa actually asked it. I was getting ready to say, we've got payers who are down coding our E&M services based on the diagnosis code. How dare
Yep.
they? They're not
Yep.
in the practice. They're not rendering the health care. They don't know what happened. And if they didn't look at the notes to see if they should down code it, shame on them.
Yeah. Yeah.
But we're not going to know if we're not looking.
That's exactly right. I mean, there's Teresa's, you know, so yes, Teresa, it is something that I definitely would say to, you know, bring up with those payors when you're seeing things like that. But that is something new that they're trying to kind of throw in there on us, is that, well, yeah, and which is another reason why we always preach about, if you know information or your documentation, you know, needs to be more specific so that you can get more specific ICD-10 codes, you know, for one thing, and use, because a patient, let's say they have a headache. Well, is it just a headache? Do they have migraines? Is there a family history of CVAs? Could it be? I mean, there's so many other things that things could be. And so looking at family histories and personal histories, you know, those Z codes, you know, a lot of people are just like, oh, you know, they take, so I got to put those in too. And then well, that's what helps support higher levels of service. You get the whole picture. If you're not giving the payor the whole picture, and I'm not saying that nobody does, because we do have some, you know, that code very well. But I mean, you know, from that perspective of it, if you're not showing them the whole picture, then yeah, they might say, oh, well, it's a headache. So no, I don't think that level 5 is right. Or not that they should do anything without looking at the record. I totally disagree with this, by the way, but I'm just throwing out there a supposing to you. Whereas if you showed those things, and in the medical record, it also stated, you know, differential diagnoses and what you're ruling out, which is why, again, looking at the documentation goes hand in hand with some of these things that you can do that, you know, is very important in revenue cycle management, you know, to get that full thought process of, you know, if you think it, ink it, you know, as I always say, you know, make sure you're getting it in the note so it's showing that process. But yeah, just to discount something because of what the ICD-10 codes are showing. I think they've tried to pull this a couple times, if I recall. That was a while ago, and that it seems to kind of cycle through sometimes. Like you were saying, you know, one payer will do it, and then all of a sudden you see a couple other payers trying to do it. And then there's a lot of pushback because, you know, for things when it's not right to be doing. So we push back, and then they pull back. And then, you know, months later, maybe a year later, you'll see it kind of start to creep back in again. So they, well, let me try it again, you know, so, which is why electronic stuff is wonderful. But yeah, you have to keep on top of stuff and be looking at stuff to see if you're finding, you know, payors will look at your practice for patterns. They look at your software when they look at the claims, they're taking ticks on everything. And they're looking for your patterns. And if you, like that mutual client we started our discussion off with, if you're an outlier because everything's a 3 when you're in the hospital, you know, then they're going to see that pattern. Well, that one payor is not the only one that sees that pattern. Everybody sees that pattern, you know, so it's the same thing on the practice side of it too. You know, you'll want to be looking to see in your remits and in these things, is there a pattern there? That's one of the things I always ask if I get a call from a client, because they start getting those ADRs, they get those requests for documentation. I'm like, well, are they all level 4s, or are they all consults, or are they all minor procedure things, or are they all, you look for the pattern, so we, or y'all, because I'm not in a practice actually anymore, obviously, but in the practices on that side of it, y'all have to do the same thing. Be looking for those patterns that are coming from the payors, because that'll help y'all get out in front of, the things that they're doing. Because if one of them's asking, they're all going to be eventually asking for it, or at least it will also show you what you should be looking at in your own practice to see, hey, we're getting a lot of these now. Let's make sure everything's okay. Is just a little recommendation I would kind of throw out there.
And we don't know if we're not looking.
Exactly. So it's important
because they sneak on us.
Yep.
Okay. Payer A is doing this again. Now we need to pay attention.
Yep.
And if payer A is saving a little bit of money for their shareholders, you better believe payer B and payer C are going to jump on board. So
exactly.
I'm just counting time. I think we should start taking bets about when Cigna brings out the implementation of their modifier 25 policy again.
Yeah.
It's been a year.
Yep. They do. It seems to kind of cycle through with them all, trying to see what they can push and how much. It's if you allow things and just accept that, then it's going to happen. Exactly. So people have to watch for things like that. And when you see something that just by nature is not fair, everybody needs to say something about it. And that's where we get that pushback, where they've had to be taking it back, because, usually once we start posting things on LinkedIn and everywhere else saying, hey, did you see that? And that's why, we do post like that. So people can say, I know in a practice, if you're a practice manager or an it's really hard to keep up on all the stuff that gets put out and everything that's going on. So that's why it's important to follow people like Pam, like me, like Rosemean and Sonal and Christine, because we post stuff like that when we get them and get the notices and different things that we watch as part of our job, and so we'll post things out there that maybe you're not aware of, that you didn't see. And gets more people kind of, like I know a couple things I've posted, some of the Change Healthcare stuff when I posted it, like, some people don't know that they got hit again. They had somebody else coming back with them and it turns out that black
cat, dog, I think
black, whatever they were, some black animal was the name of that place that did they subcontracted out to somebody else. And the subcontractors, I guess, got stiffed by the black cat people. So they got mad. And so now they went to Change and said, we still have that data, so if you don't pay us what they were supposed to pay us, that, so it didn't stop, so, and that was something else I put out there. And I think within a week, I got a thing from LinkedIn. How they'll tell you about some of your posts, the ones that are getting the most impression. It was like 4,000 or 5,000 on that. I was like, yeah. So follow people like Pam, follow me, follow Sonal, follow Christine, that's, to help you keep up with that stuff and take a look at what gets put out there. Not everything will apply to you, but you might catch something that you don't have time to find, on your own, or that just might have escaped you because the practice needs to be run and you still need to do it. And yet Jeanette, with the RAs, people are kind of, just saying, we still need to look at these things. So, very important. Just because it's being done electronically doesn't mean that it's just done and you never have to think about it. So, always be ready to put your eyes on stuff to make sure it's going out.
Well, and even if it's not electronic, Betty, just because they denied it doesn't mean they're right.
Oh, definitely.
It doesn't mean we just write it off. We need to understand, was it an appropriate denial before we go writing stuff off too?
Yes. Yeah. I was at, this was a few decades ago, when I was at a very large faculty foundation, and we had like 500 physicians in the foundation that we were doing the pro fee management for. And so we had separate payment posting department. We had a whole department of people that all they did was post payments, because obviously back then too, we didn't have all the electronic remittance. They had to do it by hand. So they had a whole room full of people that all day long, they just posted payments. That's all they did. And then they had separate, on the billing follow-up side, they had like a Blue Cross team, and they had a Medicare team, and they had it, so they like specialized by payor, right? And one day I was going by where the payment posters work. And when you would go by there in the morning, you could hear a pin drop. I mean, it was just not a peep, not a sound, not nothing. You just heard the keyboard clicking, from where they were posting all their payments. And then if you would go by there in the afternoon, it was like party central. They're in there visiting with each other, and they're all, and I asked somebody once, I was like, what is their philosophy in that department? And they had them on a quota. So they had to post so many things each day. And so they would post heads down all morning. And then once they got their quota met, then it was party time for them. And I was like, oh, I said, well, does anybody think that maybe there's something wrong with that? Something wrong with that if you see this going on? I said, has anybody ever looked at what they're posting? Like look through these things, because they would post, and if they found a problem, they would send it over to the insurance pods of people. And so we went and we're looking at stuff, and we were talking to some of them in the group, and they were actively posting something. And I said, what do you do if you have something that was billed out at, let's say, $500, and the payment comes in from the payor, and they pay $50 on that? And she said, well, they paid on it. I'm like, yeah, they paid on it. And she said, well, I write it off. I said, you write the $450 off? She said, yeah. And I said, do you look and see why they didn't pay it? She said, I don't understand all those numbers in the bottom of the thing. They just paid it, and I just adjust the rest of it off. I'm like, oh, okay. Well, if you have to post so many things a day, no, they're not.
You're not looking.
And take a look at the rest of it. They're just going to post their quota and be done with it. And this place, because they had so many physicians and it was so big, the money they were losing, they didn't even realize they were losing, because they were like, well, we're doing okay. I'm like, can you imagine how you would be doing if you were getting all of it that you were supposed to be doing? So we ended up making protocols for them. I said, you don't have to teach your payment posters to be coders or to be billers. They don't have to have, certifications, but, I'm like, no, but they do need to understand certain things of what they're looking at. So we made little sheets. If it has this remark code, then send it to, the billing department over here, or send it to, the Medicare person, or send it to whatever. So that way, it would be routed to the right person to get the correct payments coming in there. And then they, took them off the quota system, because somebody realized that really wasn't the best idea to have them do it. But yeah, they didn't know what they were looking at, So everything that doesn't get paid isn't just written off. It doesn't mean it needs to be written off. You have to somebody that understands what they're looking at to know whether or not it needs to be appealed. Is it an appealable thing? Is it a policy thing? Is it, like what? Why? What's the reasoning behind it?
Getting denials from Humana. If you've got, they started this a while ago. If you've got 2 diagnosis codes on a line, and there's an excludes one in those 2 diagnosis codes, they will deny that line, send it back to you with a CO denial, but it is fixable. Can you imagine how much of that is getting written off because people see it's a CO denial, and they don't pay attention to the fact that it's actually something we can correct and send a corrected claim?
Yes. Yes. And now I've had this question before when we start using our jargon. CO stands for
contractual obligation.
So yes, because that is one of the things that, I would tell people too. I said, you have to know what you can and can't appeal. I mean, if you do have something that is truly a policy thing where it's in their policy that it's just, we don't pay for this, and, something like that, like, Medicare has their lovely medical necessity, LCDs and all that stuff. So if you send them a chest x-ray and your diagnosis is foot pain, it's, I don't know anybody's policy that's going to be like, yeah, sure, we'll pay for that one. You send them the code for destruction of AKs if you're in a derm office and your diagnosis is a rash, they're not going to pay it. It's
Nope.
just, no, it's never going to get paid. So I don't care what you do to it. If that's really what happened, no, that's not a payable service then. So, you have to understand what things are workable and what things aren't workable, which is, that back end of the closing end to the revenue cycle that, we'll see, well, do we need to kind of take this further, or, do we need to now educate our providers and, on that these things have changed, or you can't do this with this, or maybe there's something else going on, with how we're doing these things to see, what the scoop is on it. But yeah, knowing what you can and can't take, are good. And yeah, Jeanette, both said she first said she loves this topic, and of course we do also. So thank you, Jeanette. And then yes, please don't just write it off. Yeah,
No kidding.
Yeah,
Well,
yeah, that was pretty eye opening when you catch stuff like that.
we typically work on the prophy side, right? But can you imagine the people at the insurance company that are looking at those claims that we did a chest x-ray with a foot diagnosis? And what they're saying and thinking, they must have fun with this too. Can't you
Yes.
imagine?
We do.
Oh yeah.
Luann made a little. She said she's not sure if she should say this here, but adjustment process might still be happening in some large hospital revenue cycles. Adjustment process, and I believe, Luann, that you probably are correct with, sometimes the bigger the facility, the bigger the issues they sometimes have, and they take longer sometimes to realize because they've got revenue coming in. And so just like that place I was at, it's not like in a smaller practice, if you half of your things don't get paid for, you notice that right away. In a very large place where you've got, millions of dollars coming in every year, things that might be slipping through that nobody's noticing, they don't get noticed for a long time, which is why it's important to do audits. That was my whole audits of every kind. That, you have to audit not just your documentation, but you've got to audit the revenue cycle. You have to, there's everything. You need to have audit schedules for everything to make sure that this kind of stuff isn't happening on any aspect in a practice or an organization. It's very important. Yeah, Luann is like, yeah, huge revenue, like where you work. Yeah, exactly. They just don't get noticed. So if you, Pam, had to give advice, your best practices, your kind of wish list for practices to kind of streamline or beef up their revenue cycle management, what kind of things would you say were like some tips that you could say, well, these are some things you could do, now to where you see if you have an issue, because maybe they don't have an issue, which would be great, but
Yeah, I think education throughout the revenue cycle is my number one thing, right? But and the clients that we deal with, I like the small practices, the ones that can't afford to have people with the type of knowledge that those of us that are on here have, right? Because they don't know what they don't know. So, teaching them, it's not enough just to let the system run eligibility, but you got to open it up and look at the eligibility, because it may tell you you're not billing red, white, and blue Medicare, you're going to bill Humana, right? We need to know that. But not just that, do they have their system set up correctly? Is that eligibility running electronically in the background ahead of the visit so that we're already a step ahead. You would be amazed at how many practices I talk to that they're still calling the payer to verify insurance eligibility. I'm like, you're doing what? Why? It is still 2024, right? So, making sure that they're using the tools that are available to us. Same thing on the back end. They're calling the payer to find out, to get an understanding of a denial. Well, number one, a lot of our payers, we're not talking to the same reps on the phone that we did back in the day. Betty, I can tell you there were 5 people at Blue Cross Blue Shield of Florida, and I was going to get one of those 5 ladies. Yep. And they were in Jacksonville, and they would go through, they would do 5 claims unless their phones were just really dead. And then they would do a little bit more until the phone rang, right?
Yep.
They're the ones that taught me what I know about the back end. I'd never had a coding class. I was a switchboard operator, for Pete's sake, that was bored. And they said, here, call the insurance company and ask why we didn't get paid. That's how I learned. That's how I moved into this industry. That we don't have that anymore. So the people we're talking to aren't really going to be able to answer our questions any better than we could answer them ourselves, even if we don't know. So using the tools, we have the online resources, we have the chats. Some of the payers' chats are actually really pretty amazing, and you'll get a good answer and you'll get a reference number so that when we fix it and resend it and they still deny it, we can go back and say, but hold on, wait a minute, here's our reference number, right? And it takes so much less time.
Yeah.
But it's frustrating when I'm on hold for 45 minutes and somebody answers and then I ask them to transfer me and I get disconnected. It happens every time.
Oh, yeah.
I think it's intentional. There's no transfer. They just hang up.
When I was in, again, years ago, I was in Illinois, and Medicaid in Illinois, they must have had all of like 3 people working for the whole state. I swear. You would call Medicaid, and literally what we would do is, because that music would start playing, as you were on hold. So you would just put it on speakerphone and just start doing all your other stuff and just let it go. And it would be, more than an hour before somebody would finally pick up the phone, to get, it's not fun trying to, get that. And then nowadays it's even worse because of all that automation. Where you have to go through 10 minutes of, if it's this, push 1, if it's that one, push 4. And then you finally go through all that. And then it tells you they're all busy right now. So if you want to put your phone number in to be put in the queue to be called back, I'm like, oh my gosh. So,
or the ones that told you where you were in the queue and you were like number 62. And it's like, I'm never going to get through. So the really good thing is that we have these online tools, but people have to use them. And that makes us more efficient, but it also gives us a trail because, when we request prior authorization, we can actually download the PDF right into our EMR and it's right there. Nobody else even has to log in, right? It's all right there. And a lot of our EMR practice management systems have interfaces with some of the payers that we can start doing some of this. We're doing it right in eClinicalWorks. They're sending it out to United Healthcare, and United Healthcare sending the response right back into eClinicalWorks. And being able to have those tools available, I think, is a game changer, to be really honest. Because we don't have to do the manual back end piece. There's still going to be times that we have to pick up the phone. We had a payer in one of my practices that we were getting CO 45 denials, so contractual adjustment for 100% of the billed amount. This was what we saw in our electronic remits. Now, if you guys don't know this, what we see on our electronic remits and what's actually on the remit don't always match. So we went out to the payer portal and we looked on the payer portal to see, what is this really a denial for? And it gave us a different answer, but it still wasn't clear what it was. We tried the chat. We tried all the electronic stuff. We could not get a clear answer. We did have to resort to using the phone. But the bottom line is, if we want to be efficient in our revenue cycle, we've got to use the tools that are available to us. You talked about the diagnosis linkage with services, right? In most of our EMRs, there is a setting that when a provider puts a code in, to the node or wherever it's capturing in that system, it will default either diagnosis number 1 or diagnosis number 1, 2, 3, and 4. So they don't have to type. It's supposed to be an efficiency tool. Turn it off. Make them be intentional about attaching their diagnoses to the CPT codes that they're reporting them on. Because that not being done correctly, defaulting inappropriately, is stopping your revenue cycle.
Yeah.
So there's just use the tools we have, and then plan your work and work your plan. Create policies, know what your policies are, train the policies, and then follow back up and make sure that we're following the policies, because if we are, then we're more likely that our revenue cycle is moving in a more efficient manner.
That's wonderful, wonderful stuff. So, and just the last comments I'm seeing in here with Jeanette was agreeing with our audit, run reports on the total write-offs too. Definitely. That's something you want to keep an eye on, and then look at it over time. And then, Teresa, about, the claim, calling on the status of a claim and payment for the VA hospitals back in the day was a nightmare. It took months to get something paid. Yeah, I definitely remember those days, Teresa. And then we're kind of running our short on time here, but she said another topic, billed amounts for services that are below the fee schedule amount, and the providers and staff don't pay attention to that either. Exactly. So they lose money on each claim and don't even realize it. Definitely, and those are those little things where it's just, and I had somebody once, I had a practice that told me when I had realized that some of the payments weren't onto the fee schedule, they weren't being paid what was agreed to in the fee schedule. And the comment was made that, oh, well, it's just a few cents off. And I said, well, okay, well, it's a few cents. And if everyone is doing that by every patient you see, that's going to start to add up. And then by the end of the year, it's not just a few cents anymore. You can't let that kind of stuff go and just like, oh, well, it was just a glitch, or, oh, it was just this. Look for that stuff, look for the patterns, make sure you're paying attention to it, because a few pennies on every patient, like that G2211 code. I mean, I don't have a whole discussion about it, but I had a practice that said, how much did you say it was? And I said, well, nationally it's like $16.36. I don't know the exact. I said, so it depends on your location, blah, 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 but it's going to be around there. Well, that's not very much. And I said, well, okay, well, no, it's not. But how many patients do you see a day? And then add that over to the year, and how many other providers are in the office. I said, by the end of the year, you could be talking tens of thousands of dollars. What? And I'm like, well, yeah, you do the math completely. follow it all the way through, So.
You know what? I'm going to just go. I hear it's not very much. But you don't have to do anything extra except put the code on your claim. That's a lot of money for not requiring them to do any additional documentation or any extra work. They're just paying them for the work they've already been doing that they weren't getting paid for before.
Yep. That's the thing. I'm like, you're already doing it. Why wouldn't you just add that code in to finally get reimbursed for it? It doesn't, but yeah, there was an issue with it. And I'm like, oh, well, that's up to y'all. So, but it wouldn't be money I would be walking away from, especially these days.
Well, and you and I were talking about this before, but there are commercial payers that are paying for it. So we've started billing it on our commercial claims as well. If they deny it, we adjust it off and move on, right? It's a gift code at that point. But we'll never know if they're going to pay for it if we don't bill it.
Exactly.
And so, and that's lost opportunity if we only ever put it on a Medicare claim. And when we've got payers out there, commercial payers that are going to pay for it.
Yep. Lost revenue, every dime is a dime today. It's not like, so it's worth, it's worth trying to get whatever revenue you can in the office, especially, compliantly, of course, y'all. We're not.
Oh, yes. Yeah.
So I had to add that in here. But yes. So Pam, we are at the top of the hour already. It always goes so fast when I'm talking with you.
It really does.
So maybe you'll definitely have to come back. You know how I do that quarterly thing with Sonal? We do our E&M quarterly thing.
Oh,
Maybe
yeah.
you and I will have to start doing a billing quarterly kind of thing where people
I
can come
like
and
that
we talk
idea.
about some different billing thing and have people like ask us their questions about things that are going on in their practices. If you'd be, like open to that.
Oh, yeah. You better believe it.
Cool. All right. So y'all heard it here first. So be watching to hear about some billing quarterlies now coming up and coming your way. So Pam, thank you so much, honey. I always appreciate you coming on. For those of y'all that don't follow Pam or haven't connected with Pam, this is her, and let me pull up her. I'll do it in my site inside my thing. You can connect with her on LinkedIn here. So make sure you go over and connect with her, follow her, and just watch for all the fun stuff that she speaks at a lot of local chapters. You're speaking Saturday with me too, aren't you, at the Palm Beach chapter? So both of us will be at the Palm Beach chapter Saturday, speaking for their May Mania for the local chapter. So I think the local chapters put stuff on LinkedIn on it. So, go and take a look at it and come visit with us then and listen. I'll be talking about the audit process. And Pam, what are you going to be talking about?
I am actually talking about leadership in the revenue cycle.
Oh, see, so people can hear more about the discussion from you on stuff like that.
Yes. That was a Christine request.
So thanks everybody. And thanks everybody for stopping in with us today and listening. And we will see you in a couple of weeks. I might be doing the E&M quarterly with Sonal next time. So it might be time for us to do our quarterly again. So, but you'll see a notice from me on it. So thanks a lot, y'all. And everybody have a good weekend, good rest of their week. Pam, my good friend, thank you so much.
Always a pleasure, Betty.
All right. Bye, y'all.
Bye.